let's talk about some GI disorders. And to be honest with you, this is really kind of a fun section, but I have to tell you that there are two really important topics in here. And one of them is interpretation of those hepatitis markers. So if the person next to you is snoozing, when we get there, you need to give them a nudge and wake them up. Because you've got to learn and master those hepatitis markers before you leave me today. And I think you will, because I think you'll see it's really not nearly as hard as somebody may have led you to believe. So we'll talk about that. And then at the very end, because there's so many GI disorders, we're going to do something I call the GI lightning round. And I think it'll kind of help plug up the rest of the holes that might be in your knowledge base. So let's get going. As we approach GI disorders, I always want you to remember this. The abdomen is a poor historian. The abdomen is a poor historian, and here's what I mean. It doesn't always tell you the truth. A patient might come in with a complaint of, right upper quadrant pain, and you'll think, that's a gallbladder all the way. And they might have right lower lobe pneumonia. A patient may come in with left upper quadrant pain, and you'll say, that's gastritis. The guy eats 10 or 12 ibuprofen every day. And he might have an MI. And the lower abdomen can be even worse. And if your patient is female, your differential probably just doubled. Consequently, the GI tract, the abdomen, is a poor historian. It doesn't always tell you the truth. So always remember that when a patient comes in with abdominal pain. This is what I mean when I tell you it's a poor historian. So pain in the abdomen is not always GI, but obviously you're going to look at anatomically what's in that area. So right upper quadrant pain, you certainly have to consider a gallbladder. So keep that in mind, and I don't want to belabor it. But we need to talk about reflux disease, and are you going to see a lot of patients who have this. So what do we know about reflux disease? We know that everybody in this room has reflux. You have physiologic reflux. What does that mean? You reflux after you eat. It tends to be short-lived, and it almost never happens at nighttime. Every one of us has that. But only a few of us in this room have pathologic reflux. Pathologic reflux means it's associated with symptoms like hoarseness, coughing, choking, sore throat, heartburn, chest pain. It's associated with injury to the esophageal mucosa, and pathologic reflux is the one that wakes people up at nighttime. In fact, the most common time is after 2 a.m., which is the most likely time to have what? An MI, right? So when those patients come into your ER with chest pain, they're always treated like a cardiac patient until proven otherwise. So everybody has physiologic reflux, but only a few people in here have pathologic reflux. So look at the symptoms of pathologic reflux. Heartburn is certainly at the top of the list, but only about 50% of patients who have GERD actually have heartburn, a pyrosis, right? 50% of them don't have that symptom. They have one or more of these others. There's a term you need to know, and the term is globus, Globus. It refers to the feeling of, there's a lump in my throat. When I swallow, it feels like there's a lump in my throat. That's a classic finding in patients who have reflux disease. They may or may not have some of these others. So let's talk about reflux disease. Can I borrow this bottle of water? Okay, so let me show you. I want you to look at this bottle of water. It's full. I want you to think of this bottle like a stomach, and I want you to think of the cap on the top of the bottle like the LES, the lower esophageal sphincter. One of the most important things you can teach patients who have reflux disease is to remain upright after they eat. Because patients who have reflux disease have an LES, it doesn't work so well. So if they lie down at nighttime with a leaky LES, Do you realize that if the stomach is full of contents, they're going to go up and down the esophagus all night long? The most important lifestyle modification you can teach a patient who has reflux disease is to remain upright after they eat. And all of that is because of this that goes on with reflux disease. The first thing that happens to patients who have reflux disease is their LES, which sits at the bottom of the esophagus right here, and we all have one, unless you've been surgically altered. The job of that LES is only to open up when gas comes knocking. So the LES is supposed to say, hey, who's there? Gas. Okay, I'll open up for you. Boom, the LES opens up and gas ascends. That's how it's supposed to work. But if the LES stops working so appropriately, here comes a knock, LES just opens up. And if gastric acid is who was knocking, now gastric acid is going to ascend up the esophagus. And that's a big old problem. You know why? Your stomach was built to tolerate pHs between 1 and 3. Your esophagus was built to tolerate pHs between 3 and 5. Do you see the problem? So you have got to have a properly functioning LES, or you're going to experience irritation of the esophageal mucosa. The third problem or thing that we see with reflux doesn't happen in everybody. But some poor people with reflux disease make so much gastric acid that when the LES opens even appropriately to let gas up, gastric acid ascends as well. The same problem results. The esophageal mucosa becomes irritated. And that's what helps create those symptoms that we just talked about. Now, how do we help these people? Well, we got drugs, and we got good drugs. The oldest of the drugs that are out there belong to a class called antacids. And the name of the drug class is exactly how these drugs work. They are anti-acids. So if you have a pH of 2 and you dump in some Maalox, Tums, Rolaids, Gaviscon, the pH of 2 will rise to a pH of 4 or 5 in 2 minutes. And that higher pH creates relief. The quickest way to get relief of those symptoms is with an antacid. What's the problem? The relief doesn't last very long, because in less than 30 minutes, the pH of 5 that made you feel so good is beginning to drop to a 4, to a 3, and back down to 1.5. And very often, we have return of symptoms. But the quickest way to get relief is with an antacid. When that doesn't work so much, or people are having to take them around the clock, they listen to TV commercials. Or they go to the pharmacy and they'll see H2 blockers. That's what I need. I remember that commercial I saw for Zantac. And so they'll get an H2 blocker. How do the H2 blockers work? They don't change pH. The antacids do. The H2 blockers like Zantac, Tagamet, Pepcid, those drugs work by decreasing how much acid you make. So if you're one of those people who makes a load of gastric acid, giving you an H2 blocker will help your symptoms. What do you need to know about the H2 blockers? They are a PRN medication just like an antacid is. These give relief for a whole lot longer, up to 12 hours, but they take a little bit longer to kick in. So if you know you're going to have a big blowout tonight because they're having 3-for-1 top shelf margaritas right down the street, I'm just kidding. But it is Friday, so if you know you're going to have a big old blowout tonight, you may want to take your H2 blocker right now because it'll provide relief. That's the second of the 3 drug classes we use to help people who have symptoms of GERD. The third drug class is not a PRN drug. The third drug class is a PPI. It's a proton pump inhibitor. Do you remember from chemistry what a proton was? Do you remember? It was that little H with the plus on top. You know the name of the acid that's in your stomach? What is it? It's not sulfuric acid. I always hear somebody, that's sulfuric acid. It's not that. Okay, it's hydrochloric acid. Well, listen, you have a little bit of hydrochloric acid that kind of sits in your stomach all the time. But you know what happens when you smell something good to eat? Or you see something good to eat? Your brain gets a message. The brain sends a message immediately to the stomach. Stomach, get ready. You never believe what's coming. Hot chocolate chip cookies. And the minute your stomach gets that message, it begins to produce hydrochloric acid in anticipation of hot chocolate chip cookies so it can metabolize them. So you don't just have piles of HCl hanging around. You have a little bit. You have the capacity to produce a lot of hydrochloric acid. And this is how you do it. You have a pile of H's over here. And you have some Cl's. And the minute the brain gets the message, it pulls an H, it pulls a Cl, and man, those proton pumps begin to dump out protons, and you begin to make hydrochloric acid. That's how it happens. Humans are so afraid to run out of H's that we stockpile them. We have about 2 to 3 days worth of H's just like waiting in case we need them. The way the proton pump inhibitors work is that they inhibit your ability to make H's. If you can't make H's, what else can't you make? HCl. You can't make nearly as much. So the point I'm trying to make is that the PPIs, because of their mechanism of action, are not PRN drugs. You don't take Prilosec or Prevacid or Protonix right now because you're having a blowout tonight. The way a PPI works is that you've got to take it on every day of the week that ends in Y. You got it? Every day of the week. All right? So that's how those drugs work. Now, look at this question. Because you're going to get plenty of patients who come in just like this one. When is a referral to a gastroenterologist recommended for symptoms of GERD? And it's a select all that apply. Look at number 1. It's not time to refer them if they're still having symptoms 2 weeks after a twice-day H2 blocker. Hold on. Look at number 2. Symptoms persist after 2 weeks of a daily PPI. I'm not ready to send you yet, but I'm kind of thinking you may be moving in that direction. Look at number 3. Symptoms persist after 4 weeks of a BID PPI. You're going to see GI. Circle that one. If it's in conjunction with weight loss, anemia, difficulty swallowing, epigastric mass, or recurrent vomiting, you need to be on GI's hot list to go see PDQ, right? PDQ. Pretty damn quick, all right? So you need to get in there. So what is the real point of this question? The point of the question is, when do you need to send these people to GI? Because you can't send every patient who's got GERD symptoms. I mean, they're all over your office. And GI can't see those people, but you need to make an appropriate referral, and these are the times at which you're going to appropriately refer them. 3, 4, 5, 6, 7, 8. All right, everybody got it? All right, so look at this. Why are we so interested in sending them to GI? Because GERD is not a benign disease. Look at this question. A common long-term complication of GERD is Barrett's. What is Barrett's esophagus? It is a pre-malignant condition of the esophagus. If you work oncology, you know the answer to the question I'm about to ask you. Here's the question. What percentage of people are alive 5 years after diagnosis of esophageal CA? Single digits. It's not a good one to get, especially if it's not picked up very early. Consequently, Barrett's is a precursor, and so you got to have a heads up. I want you to realize that real GERD is not a benign disease, all right? And why do we worry? Because of Barrett's. Because here's the deal. If we send you to GI, they scope you, they find Barrett's, we can probably turn you around. You know how we're going to do it? We're going to give you BID PPIs and an H2 blocker at bedtime. Because the H2 blockers don't need stomach acid to kick on. The PPIs do. Consequently, we can probably turn you around with Barrett's. But if you progress to esophageal CA, our chance of turning you around is not nearly as good. All right? So GERD, take-home point, is not a benign disease. Diarrhea. Oh! There are few things that can change your plans faster than a bad case of diarrhea. So why do people have diarrhea? It's not supposed to come out like that. So there are a load of reasons, which is why it's so darn important for you to get a good history. We're going to talk a little bit about infectious etiology and IBS, which apparently 25% of people in this room have. 25% of healthcare providers have irritable bowel syndrome. We'll talk about you in a minute. Inflammatory bowel disease, you need to know what to look for because those patients all need referral to GI, and the sooner the better, right? So bottom line, get a good history when patients come in with a complaint of diarrhea. Well, probably the most common complaint of diarrhea that you'll see in a primary care setting is someone who comes in with some bug. The most common one is a viral etiology. You got something that's running around right now, and the incubation generally is 2 to 3 days, but it can be shorter than that, and you know it can. And you know the symptoms that patients come in with. Every one of us has had a gastroenteritis. It is self-limiting, thank goodness, and the symptoms almost never last longer than 2 weeks. Acute, goes away, just keep them hydrated. Here's your patient. A 34-year-old female states that she's had abdominal cramping with watery diarrhea for the past 10 days. She complains of fatigue and weight loss. What should be done initially? Well, listen, I need to make sure you get this point, especially for your exam. But you know what, in practice too, because sometimes we just have this reflex. Oh, 10 days of diarrhea. Oh, let me give you a prescription of Cipro. Don't dare do that. Listen, on an exam, when you see that word initially, you should always be looking for a choice. It means you've gotten a good history from the patient. It's the first thing you do. Initially, you get a history. What do you do after history? You do a good physical exam. After a good physical exam, what do? You build your differential and you make a diagnosis. What do you do after that? Then you treat. You got it? So when you see that term initially in the stem of a question, initially, if there's an answer that's historical information, that's always your best answer. You see it? So number 4 is your best answer. All right? So let's go from there. When the cause of infectious diarrhea is bacterial, and it might be like with C. diff that we talked about. Maybe it's salmonella. Maybe it's staph. How quickly does infection with Staph aureus create symptoms? 6 hours. I heard somebody say it. About 6 hours. So it happens rapidly when it's bacterial. So you know the symptoms that poor patients have. And thank goodness it only lasts about 12 hours because longer than that might kill you, right? So anyway, think about that. But again, history is critically important. It is a common cause of diarrhea.